I'm quite intrigued as to how this webinar will pan out, and see if I can learn something new myself. Also, I suppose in terms of the work that Inspire is doing for Black Londoners, we'll be aware about sort of historical and social sensitivities around this area. So again, I think it's a very important topic for us as a community to look into, particularly because we've been sort of underrepresented in research, but also harmed from research as well in the past. So I think it's very important to be in this space and sort of be informed to make sort of better decisions, and also to take opportunities where they arise and to be part of change, because genomics is such a huge specialty currently, undergoing lots of transformations and advancements as well, and it would be great if the community could be part of that. So today's webinar is focusing on genetics, what matters to our community, why DNA is more than just ancestry, understanding health, heritage, and our future. So the session will consist of an informative presentation, followed by a Q&A period. I'd like to encourage everyone to submit questions through the chat, and our team will be monitoring these as well. We will address them during the Q&A session, so please do get involved. As I've just tried to mention, genomics is very vital for advancing healthcare in the UK. It's the study of our genes and how they affect our health as well. It helps us understand why some people get certain illnesses, how diseases can develop, and how treatments can work better for different individuals. Our speaker today will share lots more about this in a minute. The speaker that we have today is Dr. Chintika Piasana. She is a consultant neonatologist at the Evelina Children's Hospital at St. Thomas Hospital in London. She's also the principal investigator of the Generation study at the hospital. The Generation study is a world-leading study aiming to screen about 100,000 newborn babies for up to 200 rare conditions. So Dr. Piasana, the floor is yours. We're really looking forward to your discussion today. Thanks.
Thank you so much, Dr. Datapwa. I am so happy to be here, and thank you for that kind introduction. My name is Chintika Piasana. As you said, I'm a consultant neonatologist. And for those who don't know what that means, I look after babies who are born early or small or unwell at the London neonatal unit at St. Thomas's. I'm very happy here to speak about genetics, what matters to our community, and how we can engage with genetics even more.
It would be good if if anybody in the room has any questions that they were burning to ask, and you can start putting them in the chat room. Also, it would be interesting to know what kind of sort of concerns people might have around this, what kind of hopes they have around genetics, and if they know about the Generation study, what they think about. So I think it would be good to get the conversation going in the chat room whilst we're waiting for the slides to load.
Okay. Oh, that's brilliant. Thank you so much. But I don't think you can see me though still.
No, unfortunately, we can't see you, but we can hear you.
That's okay. I think we should get going. So, right, genetics, what matters to our community? Thank you. Can you forward to the next slide, please? So let me start by setting the scene. What we mean by genetics, we mean it's quite simply the study of heredity. So if your parents have blue eyes, then it is quite likely that the child will have blue eyes. If the parents are tall, then it's quite likely the children will be tall. So very simple terminology when we talk about genetics and what we mean by what we can inherit. But when we talk about genes, really is definitely much more when we talk about genetics. Genes are sections of our DNA that code for a molecule in the cell that has a function within the body. So genes and DNA is much more than, DNA, what we see in a crime scene, or genes are what we wear. So these are the sort of medical definitions of genes, DNA, and genetics. But the term genomics is used much more. And genomics is the study of a genome. And the genome is defined as the complete genetic information of a person. So it's estimated that we have in a human body that there are 37 trillion cells. And altogether, the DNA sequences can go into billions and billions of individual molecules that can confer a function. So the information, the complete information of a person's genome is vast, and there's so much to study and learn about this. Can you please forward the slide? So genomics is used in the NHS currently. So we can, I can stop my video. Thank you. Now, thank you. I think you can see me now. So genomics is used in the NHS currently. We use it to diagnose conditions much faster, particularly for rare conditions. So in my specialty, in the last few years, we've seen that we can now get an answer for certain conditions within weeks, when previously it was months or maybe never. So sometimes we see babies with seizures, and within a few weeks we get an answer specifically why that baby has that condition and not something else. It tells us more accurately and earlier for certain cancers, and it also helps us predict certain diseases that can happen in families. So, for example, if we know that parents have haemophilia, then we can test the baby for that same condition. Likewise, for conditions such as sickle cell disease. So knowing all of this information allows us to deliver medicine much more precisely, matching the people to the most effective medications and interventions. So given the example that I've just given about seizures in babies, if we have a genetic diagnosis telling us which particular gene, then it can help the doctors target the type of anti-seizure medicine depending on the gene without having a long period of trial and error. So you can treat the child faster and the baby has a much better outcome. And we get a better understanding of the underlying cause of many more conditions that are not considered rare. So many people have problems with hypertension or cholesterol, and with understanding, testing their DNA and their genomics, we can understand the genetic basis for that. And again, it helps us target the treatments much more precisely. Thank you. Can you forward the slides? But there are also huge knowledge gaps. I was quite interested to read this article by Professor Ambroise Wonkum from University of Cape Town, and it was published in Nature in 2021. And it is known that less than 2% of all human genomes sequenced thus far are from people of African descent. And this is despite Africa being a very large continent with much greater genetic diversity and much more people of greater diversity, and that's because humankind originated there. So therefore, our knowledge is extremely limited, with most genomic research and knowledge is based from Western and European populations. So this contributes to the ongoing health inequalities and lack of precision medicine. So currently the tests that are not as useful for everybody because the knowledge base is still very, very limited. And Professor Wonkum has this fantastic project where he wants to sequence 3 million African genomes over the next 10 years. And that's going to be an enormous and brilliant undertaking, because it would not only help people of African descent, but also globally as well, because of how diversity has how it impacts everybody across the globe, but also with health and priorities specific for people of African descent. Can you go over to the next slide, please? But we in the UK have had the National Genomic Research Library for over 10 years now, and it is part of a lot of routine genomic tests. So when a patient is offered a genomic test in the NHS, they have the opportunity to decide whether they, their child or their relatives, their genomic sequence and their health data can be donated to the National Genomic Research Library to be used for ongoing medical research. It has not been able to sequence as much as 3 million because it's a much smaller country, but they've managed to sequence at least 100,000 genomes thus far. And what's key about the National Genomic Research Library is that it's a very secure database. The security is considered industry level. The data is held confidentially and it's de-identified, and it's backed by the UK government. So unlike maybe a private provider providing genomic sequencing that may become not able to provide that anymore, it is backed by the government. So it will always be held securely. And this database is then able to offer ethics-approved research for scientists across the UK, but also internationally. And what's key is that the data cannot be removed from the library. It is kept within the library, and researchers are offered access, and the data is kept within the UK. Next slide, please. So I hope up until now I've explained a little bit about what genetics, genomics is, how we use genomics in the NHS, where the health gaps are, and how research is conducted. Let me now say a little bit about how medical care is conducted, and especially for babies. That's because it's my specialty. So this diagram shows what is a traditional medical pathway. So almost all babies are born healthy, and some few babies later on may develop some symptoms. But symptoms can be quite non-specific, and babies cannot tell us what's wrong with them. And maybe after some time, after going to health practitioners, the baby may be eventually referred to a specialist. But still, sometimes the presentations are quite non-specific, and the babies may undergo quite a few tests. And then eventually the baby might get a diagnosis. And in this slide, the baby gets a diagnosis, but many babies don't. And this pathway can take months and sometimes years. And the next slide, please. And the question is it possible to create a short circuit where we try and miss out some of that, what we call a diagnostic odyssey, where we understand the diagnoses much earlier, before the baby develops symptoms or the baby becomes really unwell. And the idea is that if you understand what the baby might be having earlier on, you could give treatments, provide the correct support, refer to the right specialists, and have better health outcomes. Next slide, please. So that sort of process of trying to understand really early on what may be affecting a baby is known as screening. So currently for babies, we already offer a really comprehensive package of screening. We evaluate every baby and we ask ourselves, do they have an infection? Some babies get a blood test. We ask sometimes whether the baby has a heart condition. We measure the oxygen levels. We examine every baby from top to toe. Every baby gets a hearing test. Every baby gets their hips examined, and some get scans. And some babies, some babies get scans. But I just want to focus on that last tile at the bottom right. But this is the heel prick blood test for rare diseases. This is offered to every single baby in the UK. There's 99% of babies take this up, families take this up, and it tests for 9 conditions. And almost all of these conditions, and the others shown on this picture, have a genetic basis. The heel prick blood test, as I said, tests for 9 conditions. Some of them are a genetic test is used to diagnose.
Just the newborn screening, do any of those tests involve genetic screening?
Genetic testing is used for two of the conditions, but it's done as a secondary test, not a primary test. So the time is now ripe for now that we have genetic technology to be able to do this, to see whether it can be used and whether it can be used to test for many more than just 9, and to be on par with other high-income countries.
Okay, so it sounds like this is already being done in other places, so it's been tested. Is that right?
Yes, I think genetics is being used to test for rare conditions as a screening in other countries. Yes.
Okay, that's useful to know that. You know, that it's not just the UK who's doing it. It's a stage in genomics that
Yes.
other countries are also exploring as well. And we definitely want to be at the cutting edge of everything. So let's hope, we're able to get there.
Yes, I just wanted to say again, the newborn screening is only 9 conditions. We now have genetic technologies that we could be able to use, and we could be testing for many more conditions. So hence, my next slide is to introduce the generation study. So this is a research study under the National Institute of Healthcare Research portfolio. It's funded by the Department of Health and Social Care, so the UK government backed. And Genomics England is a company that's owned by the Department of Health and Social Care, and it's been funded to partner with the NHS to explore the benefits of doing genetic testing, the challenges and the practicalities of sequencing the genetic code in newborn babies. Next slide, please. So the generation study has 3 overarching aims. The first one is to screen for 200 plus childhood onset genetic conditions, very similar to the ones that I've shown in the previous slide, and definitely including those, but many more that will start early on in a child's life. And the questions they want to ask within this study is, in the first instance, is it possible to do that? Is it possible to test for this many using DNA technology? Is it acceptable to people? Is it acceptable to doctors and their families? Is it useful? Does it provide a meaningful impact on the child's outcome? Is it cost effective? How does it save people money and time? And how do people feel about it? How do people feel having their baby's DNA sequenced in that way? I've already mentioned the National Genomic Research Library. So after the first part of this research is done, the DNA is put into the NGRL, and thereafter, the DNA sequences are available to discover new diagnostics and treatments. So most of the DNA already in the library is from patients with people who are accessing treatments. Here, the DNA will have the sequences from lots of well babies, and linking the DNA from those well babies throughout the child's as the child grows up, and linking it to their health record. We may explore the benefits of storing a baby's genome over their lifetime and understanding much more about not just rare conditions, but more common conditions, such as the understanding of how maybe the genetic determinants of asthma, or even things like hypertension or cholesterol problems as they become, young adults growing up. And the idea is to test all of these 3 aims by recruiting 100,000 babies across England. Thank you. For the next slide, please. So the study opened at St Thomas's in July last year. Our research midwives approach pregnant women during pregnancy. The study is explained to them in great detail. over several conversations, and interested women can give informed consent and during pregnancy. Almost every single pregnant woman is eligible. You have to be over 16 years of age because that's the age of consent. You have to be registered with a GP in England. This is important because we want to be able to contact you after you've given birth. And at the moment, you have to be pregnant with only one baby and have parental responsibility. Once signed up, the baby, a small amount of baby's blood is taken from the umbilical cord. So I could assure you that this is a very safe research study, and the patient is respected, and those patients who choose not to take part don't have to take part, and their NHS care is not diminished in any way. That cord sample is sent to Genomics England for analysis, and the result is provided from a few weeks to a few months after the baby's been born. Almost all babies will have what we call a negative research report. So we say 99% chance that there won't be something found, and less than 1% of participants, there will be the chance of what we say a condition is suspected. And if this is the case, the baby is then referred to be seen by a pediatric specialist who is a specialist in that for that condition. So remember that slide I showed where there may be a variable time going maybe to various health practitioners and eventually a specialist. The idea is that you short circuit that process. Next slide, please. And again, as mentioned, it's a long-term research study. The DNA is donated into the National Genomic Research Library for ongoing research, and then for maybe being able to identify new conditions, tests, and treatments. Next slide, please. There are several sites across London. I realise I'm speaking to a London audience, but for the south of London, Evelina is the site that's been opened since July last year, and I'm very excited to say that St George's will be opening very soon in the next couple of months. So really, really proud to be open for our communities in Lambeth and Southwark, being based at Evelina. So I would implore on everyone to spread the word. This is a fantastic way of engaging in genomics research. If we want to ensure that the research data is going to be applicable to everybody, then having as many people represented of all ethnic groups, it's vitally important that the study sample is representative of the entire population of England. So I would encourage everyone to mention the generation study and genomics in general. Thank you. Next slide, please. And I'm really proud to show here the wonderful women's health research team based at St Thomas's. I'm joined online, I know, by Molly Dillon. She's our generation study midwife, and she's running the show in a phenomenal way, absolute precision. And we have celebrated very recently enrolling at more than 500 pregnant women in the study so far. So we're extremely proud of that milestone. Next slide, please. And I'd like to direct you to this website. If you type in generation study into Google, it's the first hit, but you can also type this URL. There's a very good video that gives a very brilliant overview of the study, and you can also register your interest through that. But all the information is available for you to look at, and specifically also about the what the National Genomic Research Library entails. And I think that's my final slide coming up. So just to summarize, the generation study as a long-term research study, we are aiming to understand if we can improve how we diagnose and treat genetic conditions by looking at the DNA of newborn babies and as the child grows up. And it's done by taking a small sample from the baby after the baby's born to read their genome. And that is my last slide. Thank you for your attention.
Thank you so much, Dr. Pearson. That was really, really informative. It was really good to learn a bit about genetics, genomics, and the slight differences in the meanings, and just to get the nitty gritty detail about that, but also to learn about the generation study as well, the populations that are eligible for it, what it is you're trying to do with the study, and the hopeful outcomes currently, and also like looking into the future. So thank you for that good summary. And also it was nice because I think very often with genomics and genetics, there's lots of big jargons and language, but that was fairly easy to understand. So thanks so much for breaking that down. There are a few questions that have popped up in the chat. And some of them I'll just read out, and it'll be really good to get your perspective. And I'm aware that there's some colleagues as well from Genomics England, and I'm not sure if they have access to use their microphone, but it'll be really good to get your perspectives on some of these questions. So the first one is, I am very concerned that Black and brown people and other marginalized people are being left behind in advancements in genomics. We need to raise awareness in our communities and promote the opportunities to be involved in research. And I suppose that's a concern that's raised, the fact that sort of ethnic minority groups are sometimes marginalized and left behind. But I suppose a question that can arise from that is, how has the study tried to involve these groups in the research? And sort of thinking about the entire research cycle. So from the design and development of the research to how it will be evaluated, and also to looking at the benefits from it in the future. Like, is this something that will be really sort of impactful for our populations that we serve? So yeah, it'd be great to get your perspective on that.
Thank you for that question. I've been asked if I can put my camera on. I don't have that facility anymore. I think that's removed before during the course of the. But I can carry on answering the question. So
yes, please. Yeah, that'd be great.
yes. So through the research has been created through a huge public consultation. They've consulted various specialists, genetics, pediatricians, but lots of lay public members, groups, rare disease organizations. The materials that are presented to pregnant mothers have been done through patient and public involvement. Almost all the questions that people ask during the consent processes, the answers are in the materials that are provided.
Okay.
In terms of how is it that we try and reach everybody, they've made a lot of effort in translating the materials into languages that to translate all the materials, and they do ask us, the research teams, what languages do you come across that you need? So there is an iterative process through that. And our research teams do use interpreters and language lines to reach as many people as possible. And our research team is very comprehensive. They do try and reach every eligible woman and provide that information just so that nobody is missed out. And I guess also, the Genomic Medicine Service putting us in contact with yourselves, having these opportunities for webinars, and doing and many more, I would say, I would like to think it's a great way of reaching the communities. Because at the end of the day, almost every pregnant woman is eligible, and we want to reach as many people as possible.
Thank you so much for that thorough answer. That was really helpful. I think the next question is actually linked to that. So it says that genomics is really important to improving health outcomes. However, there are concerns about the historical nuances of the issues around the likes of Henrietta Lacks still existing today. Can you give a perspective about that? And I think, yeah, that does. It is partly a reason why sometimes the sort of the Black community might not want to be involved in this sort of work because of the history that's around things like eugenics. And I suppose how is this study trying to address that? And I think this is one way, I guess, by coming to these sessions. But again, linked to that, has there been sort of is this part of the conversation? And how do we make sure that historical injustices aren't repeated again?
So the research study goes through an ethics approval process. So we cannot do anything without the permissions to do that, without the study going through a consultation with an ethics review board. And the ethics review board includes a variety of people, not just doctors, but health leader, faith leaders, lay public. So it has to go through quite a rigorous ethics review board. You have to have a protocol, and you can't deviate from the protocol. And so the integrity of the research is judged by how the fidelity at which you adhere to that protocol. You have lots of external bodies that can come in any time to our organizations, wherever research is conducted, that can come and inspect what you do. We have to have very good record keeping. We look at every single slight deviation and address it, record it, have meetings about it. And I would say, the people who patients and people who take part in research have really good health outcomes because of that. So much scrutiny into their care, making sure that the everything is done as per protocol, by large numbers of people. So it's highly regulated and very well governed. When I think about the processes that one has to go through to undertake research, this particular study, the generation study, has been several years in preparation before it finally opens. So it's a highly regulated system, I would say, and definitely in the UK. So I would be very confident about taking part in research, such that the things that happened before, the serious injustices that happened before, is unlikely to happen now.
That's really good to hear that ethically this has gone through approval and there are lots of safeguards to make sure that it remains ethical throughout. I think just slightly linked to that is about data. I know that's not come up as a question, but very often that's something that people are worried about. What's going to happen to my data? Is it going to be leaked? Is it going to be sold to people? Any sort of reassurances around that as well?
Again, through the when you prepare a research proposal, you have to stipulate how you're going to look after the data within the NHS and within the research environments within universities, and access to data is governed strictly within the NHS and the research environments So only people who are eligible to have access to that. And we have lots of conversations about, no, well, we can't look at this, you can't look at that. Only people who should look at things, and we record only what we need to record. So I would say we do take data security very seriously within the NHS and the university systems. Within the National Genomic Research Library, as I've mentioned, it's industry level security. The data cannot be taken out. It's de-identified. It is, if you make it too secure, then you can't actually, there's no point in keeping it, because you need to make it accessible to researchers at some point, because then you are keeping data for no purpose, and that's also wrong. So if you're going to store the data, it has to have a use, and you have to make it useful to researchers and available to researchers, but it has to be highly controlled. So they've made it in a certain way that it cannot be taken out. The researchers can access it within the research environment, but they don't have access to what we call identifiers, so people's NHS numbers, dates of birth. There will be a link maintained, but that's not available to the researchers themselves.
Okay. Thank
So
you.
I would say I would be very confident about the security.
Yeah, I think that sounds reassuring to me as well. Thank you for that. There's two questions I'm going to try to link together. So it's talking about, one of them is asking, what can Black and brown people do, especially Africans, what can they do to share information and medical history with family and things like that? Because things like this, apparently, there is seen as a sort of a family curse, and it's not very often spoken about. So what can we do to make it easier to communicate within ourselves about this, about genetics, genomics, and research? And then just a little bit linked to that is, there was a big interest regarding the work that the professor was doing in terms of sequencing genomes around Africa. So again, linked to that is, how can that word be spread through our networks in diaspora to encourage friends and family back at home to get involved in that type of work?
Oh, fantastic questions. If I may go into the second question first, I was so inspired by Professor Ambrose's work. I think I'm not certain, I haven't seen anything to suggest that it's already up and running, because he would have to, to create that secure environment, the research capacity. I think it takes several years in the making. So I would keep a lookout to see whether it's available um, to people within the communities. The last time I looked, it wasn't yet available. But I would love to be able to find out a bit more about how to make it accessible to people back in Africa. I think they do want it to be from people within Africa right now to be contributing. But I would imagine, again, there's quite a lot of infrastructure to build and funding to secure, just like how the National Genomic Research Library is secure, so that people have the confidence to take part, and also have those links with universities and research groups, so that the genomes are sequenced and useful and available to researchers. The first question was, how can you talk to friends and family about genomics?
Exactly, yes.
How? The I wonder if my colleagues at the GMSA would you be able to help me answer this question?
So I
Is
think they've
there
actually put a few
patient
things
and
in the chat
public
as well.
information available on?
Sorry to cut you. They've actually put a couple of things in. I think Amy has put a few things in the chat room
Right.
for people to look through. So sort of patient information leaflets, that will be helpful in terms of sharing with friends and family, actually. So I think that might cover a lot of that question.
Thanks for that question and that answer, because me as a neonatologist working in a highly specialized environment, I only see things that things go wrong. So
Yeah. And maybe we should bring it back to neonatology. So I've got a few questions specifically about the screening. So I think one question asked, let me just find it. It asked, what are the 9 conditions? But I suspect I'm not sure if it's mixing up the 9 from the newborn screening with the 200 from the genetic screening. So I guess maybe it'd be useful just to help to differentiate that those are 2 different things, but also maybe just mentioning how those conditions were selected and why those conditions, why not anything else.
yeah, so the 9 conditions in the newborn blood spot, if one just Googles it, it comes up very easily. So thyroid function test, sickle cell, cystic fibrosis, then some conditions that one doesn't normally hear about. These are really rare metabolic conditions. So the 9 conditions in the newborn blood spot is part of the 200 that have been chosen in the generation study. The generation study conditions that have been chosen, they've gone through again a process. They developed a set of principles to choose the 200 conditions, because there's 6,000 or 7,000 conditions. They had to choose 200 that they wanted to make sure that these are conditions that manifest in early life. So as the baby grows up in the first few years, some may manifest in the first few days, some maybe 2 or 3 years. So we don't want to test a baby for a condition that only can be seen when the child is 10, 11. Wasn't the primary purpose. So something that starts early, but also each condition should have a sort of a care pathway identified within the NHS. What you don't want is to find a condition and then there isn't someone somewhere for the child to be seen. So before we opened at Evelina, we made sure that there was a doctor identified for every single condition, saying, please forewarned beforehand. So that was also a condition proviso, and also made sure that when you're testing on a genetic basis, you want to be rather sure that if there's a genetic test saying you have a condition, that is quite predictive of the condition manifesting. So because you are dealing with a baby who is currently currently well, so you have to have certain certainty that when you're seeing something on a report, that it translates to the condition. You don't want something vague, because then that will be very unsettling for parents. So those are some of the principles used for choosing the conditions. And of course, they consulted various specialists and rare diseases communities about what conditions matter to them.
Thank you so much. We are running behind, and I think I'm going to try to get us to 6 o'clock. I'm going to ask one more question, which and thanks to colleagues who are responding to questions in the chat. It's very helpful. But I just think to just take this question because it sounds like someone who wants to be part of it but has some concerns. So I understand the procedure is very rigorous, but what are the possible side effects to the unborn baby after testing? When I was pregnant with my children, I was reluctant to undergo this test as I feared any possible consequence. So I guess in terms of last words, is there any sort of reassurances that you can give for parents who might be wanting to get involved but are concerned about side effects from this?
Thank you for that question, and I really appreciate thought that the pregnant mother had put into whether they take part or not. So side effects are extremely small. So we aim to take a blood sample from the cord, the umbilical cord, so it shouldn't be painful for the child, for the baby. If for whatever reason it's not possible to take a cord blood sample, then the parent has the option of the baby having a blood test taken from their heel. So, and at that point, the parent can choose to not have that done. So there should be no pain experienced by the baby if it's just done by a cord and they choose not to do the heel prick. I would say some of the issues that parents might face is the uncertainty. A negative test result doesn't mean that the child will never have a condition. Sometimes receiving a result that says the child might have a condition might be very unsettling for the parent, because it might come when the baby's only 2 or 3 or 4 weeks old, the baby's currently well, but there's a report that says the child has a rare condition, but the child doesn't look unwell. And then they have to go and see a doctor, undergo tests, be under surveillance. So that level of that period where there's uncertainty may not be acceptable for everyone. So, but this is explained by our fantastic research team about that process. And, with full respect to people who choose not to take part in the study because they do not want that. And so, we respect everyone's choice when they choose to sign up or not.
Brilliant. Thank you so much, Dr. Pearson. That was really, really helpful. And I hope that everyone who's also joined has found that very informative. And unfortunately, we haven't been able to discuss all the questions, but colleagues in the chat have also responded to a lot of the ones that we haven't been able to discuss in the meeting. Once again, I'd like to apologize for the situation that we've had during this chat today, and we're deeply sorry for any distress that might have caused to colleagues on the call. Dr. Pearson, before we go, is there any final words that you'd like to say, and then we can round up the session?
Thank you so much, Dr. Datapwa. You've been a phenomenal host. I've really enjoyed talking to everyone here. I hope that this inspires everyone to get more interested in genomics, join the conversation, join the dialogue. I think I would encourage everyone to have their voice heard. It's important that the health priorities when it comes to genomics is tailored towards every community, and it not be determined by necessarily the academics and the people who are the funders. It needs to be from the grassroots, from the community level. Everyone must decide what their health priorities are in the context of genomics. Thank you.
Thank you so much. I think I definitely echo that. I think it's really good to hear directly from yourself, because very often this seems out of reach and out of touch to our community. But it's great that you've given us some time to sort of talk some of these things through. And I've definitely learned a lot about what's going on in the study, and I can encourage patients that I see to also sign up to be part of this. So thank you so much for today, and yeah, everybody have a good evening. Thanks again. Bye-bye.
Have a good evening, everyone.